So welcome again, everyone, to the fourth of the Sunday Conversations with MassME, presented by the Massachusetts ME/CFS and FM Association. And today's session is called Working with Your Healthcare Provider. Again, my name is Karin Dove, and I'm a volunteer with MassME/CFS, and I will be moderating today's session. Our featured speaker today is Dr. Alba Azola, who is an assistant professor in the Department of Physical Medicine and Rehabilitation at Johns Hopkins University School of Medicine and co-director of the PMR Post-Acute COVID-19 Team Program. Later in today's session, we are also going to hear a patient story from Dave and Sue, who are parents of a teenage child who has ME/CFS, and they're going to describe their experience seeking a diagnosis and treatment for their child. All right, Dr. Azola is a rehabilitation physician helping patients restore function and movement after an injury or an illness. Her expertise includes neurorehabilitation, post-COVID rehabilitation, management of autonomic dysfunction, and rehabilitation for swallowing disorders. Dr. Azola completed her residency in physical medicine and rehabilitation at the Johns Hopkins Department of Physical Medicine and Rehabilitation, where in her final year, she was awarded the Frank L. Colson Jr. Award for Clinical Excellence. Prior to residency, she was a postdoctoral fellow at the Swallowing Neurophysiology Laboratory at Johns Hopkins. Dr. Azola received her medical degree from the Ponce School of Medicine in Puerto Rico, where she grew up. After the devastating Hurricane Maria in 2017, she returned to her homeland to help with hurricane relief. If you joined us for our January conversation, you'll recognize Dr. Azola, and we're very pleased to have her with us again. So Dr. Azola, thank you so much for joining us again this afternoon, and the floor is all yours.
Thank you so much for inviting me to discuss this very important topic of the patient-physician relationship. I have nothing to disclose. We can go to the next slide. And I just wanted to start the talk by highlighting what, to me, defines a relationship. And the relationship is built by three entities. There's the person, right? Could be the patient, the other, which could be the physician, and the relationship itself is the third entity. So it is something that it's influenced by both parties, and there needs to be an agreement and flow of communication between patient and physician in order to have a relationship that will bring reward to both parties, right? And would help and work together in agreement. Next slide. Unfortunately, next slide. There's many barriers, as was pretty evident by our polls, that there's significant issues in this relationship, especially when it comes to chronic illnesses and illnesses that are poorly understood, like the barriers to effective communication that have been studied include actual evidence of deterioration of the doctor's communication skills. Years of medical training actually have evidence of suppressing doctors' empathy, and that it actually can result in derison of patients. So we understand that that is an active process happening within the system of our medical training at this time. Also, doctors are human, and dealing with emotions is complex, and there's a lot of kind of mechanisms of dealing with those complex emotions by going to avoidance, to avoid that that actual experience of those emotions, and simply by suppressing and avoiding engaging in that, and that affects the relationship itself as well. There's also been a growing trend of discouragement of the collaboration, meaning that the doctor discourages the collaboration from the patient. Patient may be asking questions about why certain tests are being done, or to understand what the doctor is recommending, or what the expected outcomes are for that patient. And the physicians, by and large, suppress that. They discourage that collaboration. And there's a perception that patients are passive recipients. But this is certainly the main issues that affect that communication. And like I said at the beginning, we have a relationship that's built with the flow of communication between both parties. So the perception that patients are passive recipients of this information just really disturbs that grounds to create an agreement and a relationship between the two parties. Next slide. And not to mention the elephant in the room, our historic reference of how populations with chronic illness like ME/CFS or other fatiguing illnesses after infectious process have been treated. I'm not going to go deep into this, but I just want to acknowledge that we're aware of the elephant in the room. Next slide. So what are the strategies for improvement on this communication? For physicians, the ACGME has incorporated communication skill training as part of the requirements of medical training in an attempt to make a step on the right direction. The idea of collaborative communication, viewing the patient as an active participant in the treatment plan. And I think that's something that for my specialty of physical medicine and rehabilitation is particularly honed in our training. We usually like to describe the patient as the captain of the team. You know, we're just kind of members of that team, and the captain makes those decisions. And we need to understand what is important to the patient in order for us to come up with a comprehensive plan. Conflict management, like any relationship between two humans, there's going to be conflict. And it's important for physicians to have the tools to understand how to manage conflict with a patient in a healthy way. Also understanding, taking time to understand the health beliefs and the values of the patient so that we can better serve them, achieve their goals. Next slide. And I just, another issue is that interpersonal trust, which needs to be built between the physician and the patient. It can be interpersonal or interinstitutional, right? So it's a complex trust system, but in order for physicians to establish the trust between in that relationship, it's important that we build the relationship as we know that a healthy trust relationship between patient and physician definitely leads to better medical outcomes and better quality of life of patients. Patient trust between the patients and physicians correlate a lot with the patient's perception of the ability to communicate of the physician, the level of interpersonal treatment, engagement of that patient in the treatment plan, and patient's perception of the knowledge of the patient, which I thought was really interesting, and I have seen that a lot. So engaging with a new encounter, with a consultation with a patient, you know, taking a look at those records, getting some highlights of what has been happening, and coming in with some basic knowledge about what has transpired in the patient's history. It's important, and it's very valued by the patients, and it builds trust. The way a doctor communicates with his or her patient is as important as the information he or she is conveying to the patient. So you can have really deep understanding of a physical process, but the way that the doctor is able to communicate that with the patient, it's what's really key in terms of getting the information received in that exchange between the two parties. Next slide. And this other part of my talk, I'm going to spend a little bit of time talking about what is a medical visit structure, kind of the basics of how physicians are trained to assess a patient in order to obtain the information that's needed, in order to check for positive, pertinent, negative information of the patient history and symptoms. And that really helps us build an understanding and inform how we can create an assessment and plan to put in place. Next slide. So we start with the history of present illness. And the goal is really to get as much information as possible on the current issue that the patient is presenting for evaluation. But we're really trying to also get that information in an organized way, in a methodical way. What's essential, and it's been extremely helpful, it's patients that come in with a chronological outline of the events that have transpired throughout their illness or throughout their lives in a summarized way, just to highlight the main points, so we can keep that thread of the story, right? The main threads of the story of what's been happening. It's also really helpful for patients to have organized medical records. Unfortunately, due to the way our medical system operates, compared to other places in Europe where they have shared electronic medical records, in the US, we do not have a common electronic medical record. So our access to evaluations and testing performed at different institutions are not available for us to see. So in the cases where it is, it's extremely helpful. And when it's not, it can be a real challenge in order for us to fully understand what has happened. For example, with imaging, it can be quite tricky because imaging can be read with different eyes. So for example, a CT scan or an MRI has a lot of information that to one radiologist who's not a neuroradiologist specialized in recognizing certain areas or certain subtle changes may not be able to see. So it's important that if you have the studies done in an institution, get the CD copy, or at least a way to access the electronic images themselves. So getting the read of the imaging is not very helpful at all. We like to actually see the images, and sometimes have different radiologists do a second consult to give us insight into what they can pick up from those images, which may be different than a different radiologist is trained to see. Next slide. Also, I find really helpful that patients describe their symptoms in their own words. A lot of patients that have been sick for a while, have had to advocate for themselves, have had to immerse themselves into the vocabulary of the medical field, and that's valuable. But at the time, at least for myself, the time that I'm getting to know the patient, I want to know what their body is experiencing. So I want to know exactly what they're feeling and what their sensations are, what the what is the voice of their bodies telling them. It can really help me guide without having preconceived notions or kind of jumping or understanding. Some people may have a different definition for a diagnosis, and in terms of chronic illness, that can become an issue. So you want to have beginner eyes as a physician, and you want to get that patient experience not metabolized, but raw. We want to know the current functional status, like what is limiting your mobility, your ability to do activities of daily living, what type of activities do you require assistance with, and get a sense of where the limitations are, so that we can then look into these and find ways where you can regain some autonomy, regain some ability to be more independent. And that the field of physical medicine and rehabilitation, it's specialized in just understanding the functional status and understanding how we can make things that may give you some independence, may give you some autonomy, and they don't have to be done exactly the way that they were done before, but we can find creative ways to achieve that independence. And something that's really important in that first meeting is there's a lot of information. There's a lot of complaints and things that you're experiencing, right? Try to highlight what are the top three. What are those top three? And those may change through time, and they will change through time. I call it the whack-a-mole. New symptoms get better, other symptoms get worse. But it really kind of keeping the visit with kind of what are the three things that are most getting in the way of me living my life, right? That can be really helpful if you can think of that, because that gives the physician then a point of view of what's important to the patient and what we need to prioritize when it comes to creating a plan. Next slide. Then we do a review of systems. And in the review of system, it's a portion where we kind of go head to toe, checking different symptoms of different areas or systems in the body. It's a lot that we need to get through in order to get kind of that section of our assessment. And I just want to mention, like, I feel personally, I experience that I sometimes seem to be cutting off the patient, and I try to be as sensitive as possible, but it sometimes comes off as cutting off. But we're just really trying to get through a systematic assessment. So sometimes we have to redirect the conversation. We want to get to know all the details, but there's a little bit of a balance of really trying to get a head to toe understanding of the most critical issues. We also want to know what you're experiencing, and I talked a little bit on that already. We don't want to say, or when patients tell me, oh, I have tinnitus, I stop them and I ask them exactly what are you experiencing? What is this tinnitus? Is it a ringing? Is it a thumping? Is it a pulsatile sound? What is it that you're experiencing? And that's kind of the information we want to get at. Or saying I have migraines. What are your migraines? Like, where are they located? What is, when do they get better or worse? So it's more like we want to learn about what are the specifics of it and not what your perceived notion of a specific diagnosis is. It may not speak the same to a different physician than it does to you. Next slide. In terms of medical history, the current medication list is important. knowing specifically what dose you're on and how long you've been taking those doses. Also, extremely important and helpful for physicians is to keep a list of medications that you have tried in the past but are not currently taking. And we want to know which medication it was, what specific dose it was, what side effects were the ones experienced that led to stopping the medication, how long did you trial it? We want to know those details because we want to know if the medication was tried at an optimal dose, or perhaps it was stopped due to a side effect that may have been caused by a different medication. So it's just important for us to get a sense of what exactly were those medications that you've had in the past and how they kind of were dropped off your list. Next slide. In terms of past medical and surgical history, again, super helpful to keep a running list of past medical history, including pediatric issues. Keep a list of surgical procedures and other interventions and complications associated to those procedures. Next slide. Next slide. Yeah. Past family. Oh, you can go back. Perfect. Past family, social, and functional history. It's very useful to have clarity on your family history. There's a lot of hints and clues that we can find on family history that can change the course of our workup or allow us to or raise a red flag for something that needs to be ruled out or that we need to think about. So those things are really useful if you can, before coming in, kind of have time to talk about that with your family and have clarity on what those family medical issues are. We want to get to know your environment. We want to get to know where you live, what your house looks like, who lives with you, what your day looks like, what do you do for work. The doctor needs to know that in order to understand the context of where you are, right? We're trying to understand not only the patient and their symptoms that they're experiencing, but how that matches in the context of the environment the patient is living in. And that's also going to be helpful for us to provide input into how to make that environment work better. Next slide. Assessment and plan. The providers may not be able to create a comprehensive plan at the end of your first visit. And I'm just putting this out, that statement out, because it's a lot of information when you have been suffering for a long time and you have been seeing multiple specialists and given a number of diagnoses. And it takes some time to process that information. So it's important for you to understand that at the end of the visit, we're not going to be able to say these are exactly the next steps that we need. We try to come up with a comprehensive, or at least some direction for next steps, but it's going to take time in order for the physician to be able to develop a comprehensive plan. And like I mentioned earlier, a lot of the symptoms fluctuate in intensity, fluctuate in severity, and through time. So it's not, we're not going to have the magic answer at the end of that first visit. It's very important that the patient expresses what are their priorities. And I kind of mentioned this before, but I want to highlight that, in the plan, it is important that you convey, these are the things that are most important to me right now, and how can we proceed forward. And there's been occasions where the physician or myself have different priorities. So it is important to have that conversation, because like I mentioned before, a lot of physicians, or historically, the physicians tend to think that there's a one-way communication, and that can disrupt that relationship, right? When the physician just states what's important to them, it's important for the patient to then also report what is the most important thing in their health priorities, and then come to an agreement in terms of the plan. And ask your provider. I mean, this is why are you recommending a skin biopsy? Why are you recommending a tilt table test? Or what is this gonna bring to me? And sometimes, I explain to the patient why that is important, and they may decide that at this moment that's not important to them, and then we hold off on doing a particular test and prioritize something else. So it is an important conversation to ask why the physician is proposing certain steps in the plan. Next slide. Your doctor, after the visit, your doctor needs and wants to know if you had stopped a medication due to a side effect. So if the doctor prescribes you a medication and you're not sure that you want to take it, or you decided that you don't want to take it anymore, it's important that you notify the physician. It's different for each institution, but we have a pretty accessible system where patients can send electronic messages through our electronic medical record. It's really important that that communication is there. Also, if you see another provider that has a conflicting recommendation and you opt for changing the medication per the recommendations of the other provider, we're not going to be offended. We need to know. Like, it's not going to make the physician mad. We want to know because, we're invested in this relationship and we're making recommendations, and we want to know where you are. And, just knowing can become really helpful and can create more of an agreement in the relationship. If you have an exacerbation of symptoms that's setting you back, or sometimes a medication can cause an exacerbation of symptoms, it didn't work out for you, we want to know. I find sometimes patients feel like guilty, or they don't want to come. I don't know what the patient is thinking, but sometimes they won't communicate that information. And we really are here to help the patient. And sometimes we're making recommendations best guided by our best understanding and knowledge, but that's not perfect. And by any means, everybody reacts different to different medications. So it's important for us to know what happened, and we like it better when the patient tells us right away. Next slide. So what are the ways that a patient can help a physician that's trying to, or that you're engaged in a relationship with, to manage chronic illness? I think facilitating communication between providers has been something that has helped me, not only medical providers, but also psychologists that they may be working with, or social workers that they may be working with. That can be really useful, just getting them their emails to each other. So facilitating that communication, giving, a lot of the times, and not a lot of the times, the people that you want to share information between should have paperwork with release signed, giving your approval to share information. And taking that initiative from the patient's side can make that process a lot smoother. Also, discuss what's the best communication method and expectations in communication. And this one it's particularly important because, for example, electronic medical record messages don't usually go directly to the physician. They usually go through an office that screens them. So it may take 72 hours for the physician to get that notification. So you need to be aware that there's going to be a gap. And if it's a communication that you expect a return in the message in less than 24 hours, or you're conveying something that would qualify as an emergency, for example, that you're having chest pain that gets worse with activity and gets better at rest, and you were getting sweaty, or things that would raise red flags about needing medical care sooner. It makes it really difficult to receive that message 5 days later, and as a physician you just try to get a hold of the patient as soon as possible, but it is important that you understand that medium of communication is not for immediate response. And then keep it real. Let your doctor know how you really feel. If the medication is not working, let them know. If you have any clues that may chime, anything that you're experiencing, we really want to know. We want to know what your experience is. It's going to only help us serve you patients better. So the clarity and the transparency in communication, it's truly important. Next slide. That's it. I hope that this is helpful and open to answer questions, and excited to listen in on the generational conversation after this.
Thank you so much, Dr. Azola. You covered a lot of information today, and I was looking through the chat, and there's a lot of comments in there and questions in there as well. So I can't wait to get to that part of our session and then get that discussion going. So now we're going to turn it over to Dave and Sue to hear their story. So I'll turn it over to you both now.
Hi.
Hi, thanks for having us. We're sharing our difficult story, so hopefully some of our experiences, and we can learn from some of yours and figure out how to do this better. Our Ben has ME/CFS. We're not using Ben's real name. He's really asked us to respect his privacy in this process. But Ben's symptoms began in December of 2020 and from a concussion. He spent most of his time laying around on the couch as a teenager. And the concussion clinic really advised and pushed for active aerobic exercise as his therapy, which we supported, and he found to be absolutely torturous. The only relief during this period came when he took 2 weeks completely off from school, and around one of, they had a week break. But then symptoms came back after just 1 day of school.
In March of 2021, his concussion neurologist told him symptoms were no longer concussion related. And after ordering an MRI, which identified abnormalities, just discharged him from that practice. Our pediatrician referred us to an endocrinologist to check for Cushing, since Ben had Cushingoid symptoms. But Ben's cortisone was in normal range, so we were sent back to the pediatrician. Meanwhile, Ben was missing a lot of school and being accused of school refusal. So with no diagnosis in hand, they said he needed no medical diagnosis in hand. They said he needed to be in a program or in school. So he attended a partial day program via Zoom for teens with anxiety and depression for the last 2 weeks of school. He did seem better for that versus school.
We ended up traveling a lot that summer, and Ben crashed terribly during the trips. Even though we by then had been started using a wheelchair, we had bought our own wheelchair, and we tried to limit his activities as much as possible. We didn't understand what was happening, but through Google and everything else, we started to suspect chronic fatigue syndrome. Our pediatrician found and referred us to Boston Children's Complex Care Clinic, and we had our first appointment in August. That physician diagnosed Ben with ME/CFS and gave us Dr. Rowe's pediatric primer to read. We finally felt listened to and hopeful. We asked about getting a prescription for a wheelchair that Ben could use, and felt it wasn't necessary and was confident that Ben would end up be up at, although she did advise us that it was slow medicine. The doctor also recommended bupropion, which helped with energy, but Ben then became severely anxious and was unable to sleep. So we were also referred to cardiology and neurology. Ben started school that September in 2021, this past September, rented on our own, and an accommodation from the load a quarter of the normal load.
After just 2 days, crashed so severely that he is bound, and he basically has been since. His condition has worsened progressively with orthostatic intolerance and a host of other new symptoms. I'm sure many of you could name them off the top of your head. Got the first cardiology visit that doctor had recommended in October. The cardiologist prescribed fludrocortisone, but lectured Ben that there was no reason he couldn't be walking around. And they recommended physical therapy, which we declined. And Ben was actually frustrated that we seemed to be arguing with the doctor. The neurology visit was 5 months out, and we never saw that neurologist.
Last fall, Ben had a particularly bad night where they had a new. They were saying that they felt paralyzed, that they couldn't move their arm. And their speech was becoming slurred and slower. And we were terrified that he was having a stroke, and ended up calling 911 in the emergency. Amount of time that it took for us to get there, Ben started to feel a little bit better. And the attending really just treated Ben in a very condescending manner and really made light of their difficulties walking. We were given a diagnosis of functional neuropathy or neurosis, something, and referred to a neurologist. So we got in to see a neurologist, not the original, pretty soon after that ER visit. And their focus was really functional neurology. We discussed the ME/CFS diagnosis, and this neurologist claimed that the only evidence-based treatment for it was graded exercise therapy, which we politely said wasn't. She initially agreed to order scans to evaluate CCI, but she told us she didn't believe in those diagnoses, and she changed her mind about ordering the scans after we left her visit.
All the doctor's visits and tests exhausted Ben even more. In addition to bloating and exhaustion, Ben was complaining about severe pain. So in late November, we reached out to our pediatrician, describing the bedbound status and pain. The pediatrician was alarmed, contacted the children's hospital specialists and Ben's psychiatrist, and they jointly told us they wanted to put Ben in the hospital for inpatient observation. When we asked what the plan was, they said that would be made by the attending physician, likely involving observation of the post-exertional malaise, psychiatric evaluation, and visits by neurology and other specialists. They kept on telling us how rare Ben's illness was. We let them know that we didn't think an inpatient stay would be beneficial for someone with ME/CFS, and we referred to Dr. Rowe's paper. We were concerned that We were being perceived as parents who were withholding care for Ben. We were concerned that we might be forced to admit Ben to the hospital. At this point, we reached out to MassME, which felt like a lifeline during this stressful period.
We pleaded, as we actually had been for a while, with a physician for a physician-to-physician consult with Dr. Rowe. Our pediatrician finally agreed and had a long conversation with him. She withdrew the recommendation for the hospital admission and called us to let us know we should talk after the holidays and develop a plan. At the follow-up, she let us know that Dr. Rowe had given her advice about Mestinon and low-dose naltrexone, some of the therapies we were asking about, but she didn't feel comfortable prescribing any of those things. And she recommended we see another cardiologist and also mentioned a doctor in Rhode Island that might be willing to prescribe low-dose naltrexone. We left that visit without a plan and feeling totally abandoned by our regular pediatrician.
We saw a second cardiologist via telehealth who was more empathetic, but told Ben that his psychologist should be a coach to help him be more active. He didn't have any experience with ME, and we haven't met again. Fortunately, we had connected with a physician in Northampton on recommendation from Rivka from MassME. Hi, Rivka. He has some other patients with ME/CFS, although no pediatric patients, and has been willing to listen and take Ben's illness seriously. The visits are via telemedicine, and after the initial one, we have a call every 6 to 12 weeks. So it's critical for us to prioritize the issues in order for us to make sure we're getting to the most important ones. We also need to slow the physician down sometimes so that Ben can follow what's being said. He continues to be brilliant, but his processing time is slower.
As parents, we're still worried that Ben's not under the care of a physician who actually sees him in person and can do a physical exam, but at least he's being treated. We're still looking for ME knowledgeable specialists who will treat patients under 18 in the Boston area, and looking in particular for help with sleep and dysautonomia. Lessons that we like to share, which I think many of you already know, and maybe we learned from you, are, don't waste too much time with physicians who are not willing to understand. Get accommodations early. By the time we got a wheelchair and a stair lift for Ben, it was really too late for him to use them. He was too exhausted already. Be willing to respectfully question your physician's advice, even if it doesn't make sense. If it doesn't make sense with what you know about ME/CFS, and really get support from other patients and parents. We've turned to this group into a Facebook support group for parents with kids with ME to get better insight into treatments, providers, and just validation when we weren't getting it from the physicians. And this has been important even with a physician that's been really terrific to work with. Sometimes the treatments that he's prescribed, we've needed to get some insight on how best to implement. Prioritize symptoms and questions to be able to take best advantage of the limited time that you have with doctors. We find that we have a planning meeting where we write down what we want to ask and are in agreement with our son about what's important to him. We hope that groups like at MassME can go ahead.
Succeed in fostering relationships with physicians and the professional organizations to educate more doctors as well as the general public about this illness. And we hope that can result in care that's better suited to this illness. For example, more possibilities for home visits. And
we really also hope there's just more support for primary care physicians. I just feel like our pediatrician really tried, but at some point she just felt overwhelmed and gave up. And then we didn't really have anywhere to go.
All right. Thanks.
Well, thank you so much for sharing your story. I know it's a difficult story, but I think that almost everyone on this call, if not everyone, can really relate to at least one aspect of your story, whether it's having trouble communicating with the doctor, having them take them seriously, having them believe them, so many different things. So I'm really appreciative to you for sharing your story today. And so now we're going to turn to the question and answer portion of this presentation. We've gotten a lot of questions already, but if you haven't asked a question yet and you have one, feel free to enter it in the chat and we'll go through these questions. Also, one thing that I want to ask the group is, the whole audience, is what kind of ideas you have for improving the doctor-patient relationship. So we've heard a lot of things, both from the doctor side of things, as well as the patient and the family. And if you have any thoughts for what could be done to improve this, we'd love to hear them. And also, if you have things that you or your doctor have done that have fostered a successful partnership, we'd love to hear those too. So feel free to put those comments in the chat, and I'll just put these questions in here. So that you guys can have them to look at. All right, there we go. Okay, so we have a lot of questions. Let's see. I think one of the questions that came up is that what kind of advice, this could be for Dr. Azola, or this could be for Dave and Sue, but you know, what can patients do when they aren't able to just go from doctor to doctor to doctor? You know, they might find a few doctors that have not listened to them or aren't getting them the help they need. And what should people in that situation do, especially those who are, you know, maybe they're on Medicare and they have fewer options, or they have just so little energy that it's difficult to go just select new doctors all the time?
Yeah. I just want to speak a little bit about access to medical care. It's definitely an issue in our current medical system. Insurances restrict which physicians you can visit, or you know, what locations. It's just very, there's a lot of barriers to access to medical care, particularly for specialized access to people with understanding of certain chronic disorders. So my hope is that this pandemic will open doors to educating patients that have chronic illnesses. I think that it's going to open up access by increasing the number of providers that are going to feel comfortable treating this. I personally think that, for example, the Academy of Physical Medicine and Rehabilitation has been taking an active role in spearheading education for other providers, creating consensus guidelines, learning from providers that have been treating these disorders for longer. And I think that that's going to improve patient access. But I definitely think that part of it is the medical system that we have in place. But another part is the limited amount of physicians that are trained or understand how to manage this patient. So hopefully one of the things that will come from the pandemic will be expanding that footprint.
Thank you. I think one other question that has come up a lot is that really right now the onus seems to be on the patient a lot of times to be educating the doctor about what is ME, what are the symptoms, that it's not psychological. So do you have any advice on how that could be changed so that it's not just, the burden isn't just on the patient to be bringing that information with them and trying to persuade the doctor?
In terms of whether it's something psychological, like that they think the root of it is psychological? Is that...
or just that, you know, how can we, do you have any thoughts on how this can be changed so that doctors are learning about it in other ways so that they know about it already when the patient comes in there, the patient doesn't have to introduce this disease to them each time they have a new doctor?
So that's going to take a more, so basically we don't get taught about ME/CFS in medical school. It's not part of the curriculum. Again, I'm hopeful that, you know, highlighting with this new surge of patients with this disorder, that's going to highlight the importance of educating the clinicians. We know that most of the primary care physicians are going to be receiving these patients, and we need to educate them. So there's, I think that we're already starting to create documents, and there's echo projects that we're using to educate other primary care physicians and outreach. However, I think hopefully it'll lead to a change in the exposure and earlier exposure to physicians regarding this conditions. But there's a lot of ground to be covered in order for that to happen.
I feel like there's also one thing that I found surprised, and I think it was just at our last visit, Ben asked the doctor, how come when I look in my clinical notes, because he asked to see them, I never see ME/CFS as a diagnosis that's put down. And one of the things he was told is, well, there's not a DIAG code for it that can be used for insurance and billing purposes. And I just think, just not even having a diagnosis that, and maybe that's correct or incorrect. I haven't actually verified that information. But I feel like it's not even something that's sort of well defined, even though it's, on the CDC has it as a diagnosis. The fact that it's not something that's a billable diagnosis in the coding system seems a little bit like a barrier to getting accepted and used. So it's always being described as something else. So they have.
There is an ICD-9 that you can.
Okay. Well, so we need, that's why I said I haven't verified that, but that was what we were told. And it was like, oh, that just seems strange, Yeah.
Like I said, it's difficult for physicians that don't know that exists to just say, okay, I want to take responsibility of making this diagnosis. It's intimidating for the physician that doesn't understand the specific criteria or doesn't have familiarity with it. So that's part of why I think people don't code it or add it to the diagnoses, because it's just something that they're not comfortable diagnosing. And also we want to make sure that we're identifying the symptoms and ruling out other causes for similar symptoms. And I feel like this audience kind of, has a lot of suffering and has gone through a lot. But I just want to highlight that as physicians, when you present initially with fatigue, we want to make sure that this is not a new cancer diagnosis, or that there's nothing ominous that, that we can actually, take steps to treat it with pharmacotherapy that could be curative, right? So it's important for us to sometimes just go through the symptoms and make sure that the things that we understand and know how to treat and know that they respond well, like those are being ruled out. So that's part of it too. I feel like, it's a tough position to be in right now. But I don't want to defend, the whole institution of medicine, but definitely there are reasons why sometimes physicians will be hesitant and want to make sure that they're not missing out something else.
So this next question is directed to both of you. So Dr. Azola, from your side, what kind of language can patients use to really get across like how exhausted, how tired, how limiting their symptoms are, that it's not just someone who's tired or who hasn't slept well, it's just like extreme symptoms that aren't just fatigue and tiredness? And then
Right.
Dave and Sue, on your end, if you have any ideas for vocabulary that you use that really seem to get across to the physician how much was going on, I'd love to hear that from both of you.
In terms of the fatigue, yeah. So when people say fatigue, that can mean so many things. And I started seeing this population in the summer of 2020, and about a year after that, we had some meetings with researchers that were trying to work on post-COVID conditions research. And they were like, fatigue, but everybody gets fatigue. And I was like, no, this is not the same, just fatigue, right? I find that a lot of patients describe a heaviness, like a lead feeling in their body. That can be useful. Feeling like they have the flu, those type of descriptions, or exacerbation of specific symptoms. I give my patients an activity diary so that we can kind of pinpoint what is causing the exacerbation of symptoms. What's the temporal relationship? We know that it could be 24, 48 hours even after a particular activity or event or emotional situation. So I think that it's important for patients to tune in and give words. I know that there was a lot of comments about feeling unable to describe what they're experiencing, but I cannot underestimate the value and that information conveys versus somebody saying I'm fatigued. Actually, explain like I feel like I have shards of glass stuck on my legs, for example. A couple of my patients tell me that. Those are things that are important to understand. Yeah, for the physician, that it's just it's not just fatigue, right?
Yeah, in our case, I feel like it just when for better or worse, when Ben started to become really limited, that made it easier. This kid can't walk to the bathroom on his own anymore. That certainly gets people's attention. For those who, when Ben was less severe, yeah, it was really tough. Almost getting back to the previous point, I feel like, gosh, it would be nice to if there were more examples in the public consciousness to point to as a celebrity for us, but not in the wider world. Whitney Defoe is a celebrity for us, but not in the wider world. You might imagine that long COVID, there might be some natural spokespeople to come out of that and just to get that public understanding. And then eventually, I think that can help in then working with whatever medical schools and hospital heads and things like that, just because it's more in people's consciousness. It's just hard to go from scratch when there aren't the examples out there. And we struggle that without ourselves, to be honest, for so long. It's just.
One thing I think was helpful is, we were able to describe some changes as an observer that happened that maybe they weren't even aware of when they were in these states. Like they had significant changes in the cadence of their voice, in the tone of voice, when they get really tired, like some of that brain fog, they may not notice that they're talking completely differently, but they sound completely different. And I think some of those types of observations are also sort of helpful, that may be harder as a patient to identify because you may not even be aware of it, but the people that are with you might have some observations, and that may also be helpful.
Presence of caregivers during the visit is key. Those visits can be really exhausting and cause a flare, and you may, kick into brain fog in the middle of it. And having somebody there who's going to be able to help get the message that the doctor is giving, as well as explaining to the physician what they're observing, it's definitely key. The other one that gets me, it's always like the washing their hair and showering. I feel like that one's very common. Like it's impossible. Like, and some patients will be like kind of like scared to talk about it. But when I ask, it's just very telling of the level of symptoms that they're experiencing. Yeah.
Thank you for sharing your perspectives on that, both of you. This next question is for Dr. Azola. So physiatry is a medical specialty that I think it's not very well known to ME patients as maybe some other specialties that ME patients see, like immunology or infectious disease. So could you talk a little bit more about how that specialty might differ than others, and what kind of value it can bring to ME patients?
Right. So the specialty of physical medicine and rehabilitation is a specialty that looks at care of patients with significant impairments and disabilities and helping them restore functionality. So our viewpoint is very much, or our training, it's mostly with communities such as stroke patients, spinal cord injury patients, traumatic brain injury patients, patients that had critical illness that cause significant musculoskeletal issues like critical illness myopathy. So we basically want to restore function. That's the goal of a physiatrist. So we understand the musculoskeletal system pretty well. We also understand in general the medical influences on function. For example, we have different subspecialties like cancer rehab, and where the cancer rehab doctors are trained on understanding what different chemotherapies cause to the body and how they can manage that. In the case of ME, I found, I really just stumbled into this field, and I understand that it's a really good match, and there's a lot of other physical medicine and rehab doctors that are starting to just jump into this field because we understand the value that we can bring to the patient care. I come from an institution where I have, Dr. Peter Rowe and Dr. Tae Chung from the POTS Clinic. They have, I can call them or email them and meet with them and help me kind of guide how to manage this patient. So so I'm in a privileged position to be able to do that. But other people in other academic institutions have had the same experience and have taken the role in post-COVID clinics. And like I mentioned, we're kind of meeting and creating educational information for other people in our specialty on how to be able to best care for these patients. So it's a growing field, but we're not immunologists, we're not neurologists, although I would say neurology, it's pretty close, and we're kind of the functional aspect of neurological disorders. But yeah, we're kind of like general practitioners for people with severe impairments. Yeah.
Great. Thanks. Okay, I think both of you could answer this question. So when is the right time? Like, when do you know that this doctor is not working, and what kind of signs should you look for when deciding that you maybe need to look for another doctor?
I think for us, it's really been when they've given us complete misinformation and haven't been willing to sort of take in a different perspective. So, an example, we gave the GET example. We had another example where Ben had been progressing, and it was around the hospitalization, and one of the doctors who was actually the person who diagnosed Ben actually said, well, it's just really unusual for people to progress this way. This doesn't really happen. So it mustn't be ME/CFS. There's probably something else. And we certainly understand them wanting to look for something else that may be causing it, but the sort of notion that if you have ME, you couldn't have this type of a crash and become bedbound seemed to me like we were dealing with a physician that really didn't have a lot of experience and knowledge. And then especially, when the physician is looking at other resources, like papers and things about it, that, looking at the expertise to me, or consulting with folks that are experts, to me, that's been sort of a sign of, you have to have somebody who's willing to engage, because it is hard and you're not going to find someone who knows everything, but they have to be willing to know what they don't know and willing to try to help you figure out those answers elsewhere.
I think that, like I was mentioning before, the medical system, the way it's set up, there's incredible amount of burden of burnout, compassion fatigue. difficult when you're not able to make your patient feel better or become more functional. You can jump into avoidance behaviors like I was describing before. And I think as a patient, I would say, understand that the physician is also a human and they have their own issues, and it may not be personal. It may speak more of their issues with struggling. It's complex, and I think that in order for patients with chronic illnesses, chronic fatiguing illnesses, to be able to receive care that's comprehensive, you really need to find a person where you can create that relationship and you can have the flow of information, and you're able to work on that relationship, both sides. If the physician is not engaging on that relationship, then that's not a good fit, right? You need to have both sides contributing so that you can create that agreement between the two parts. And the patients, I mean, it depends on personal issues too, and historical issues. It's a tough situation. I mean, I'm just reading the comments on the chat. It's a little bit overwhelming because it's tough, right? As a patient, I mean, that is suffering, that is having severe impairments, that their lives has completely gone upside down and they're not able to be themselves, right? Or what they were, and trying to look for answers in physicians. And sometimes, I mean, on my better days, my best is not enough. And I just have to kind of live with that. My best is not enough. So it's something that the physician has to be okay with. And sometimes that can be difficult for a physician.
Yeah. Thank you for sharing that. Okay, one other question that we have here is, this one's kind of for patients who may have been sick a really long time. So maybe if you just got sick and you go to the doctor, you have kind of a short window of time where you have your history that you're sharing. But for patients who have been sick for 15 years or 20 years and they go to a new doctor, what kind of pieces of information does the doctor want to know when there's so much that could be contributing to the illness over those years?
I think that it's important for those patients, when they're seeing this doctor, what is specifically their top three in that moment? What are the targets? What is really their main impairments? And then as their relationship forms and grows and continues to have visits, you'll continue to learn more of the information. And I think sometimes it's useful. I know this is hard to create the list and kind of a chronological order. It is difficult when you have brain fog and when you're experiencing severe fatigue, but if a caregiver or anyone can help you do that, that's really helpful. And your doctor may not be able to read it at that moment, but when they're looking over your files later, or they can revisit that, and if it's in bullet points, it's really helpful to give you context. So I think trying to target those top things that are bothering them in that moment is important. And then, kind of giving that information in a summarized form can be helpful, because sometimes we have an hour and you're going through, 10, 20 years of history with so much pain, so much attached to it, right? And it can be overwhelming, and the physician may feel like, I don't know how I can help you. Like it just feels too overwhelming. So I think always summarizing it to those top 3 things that we can target is important.
Yeah, thanks. So I think we're gonna wrap up this question and answer session, but I just have one final question, and this one's for Dr. Azola. So, it sounds like from what you've shared with us, you came into this field with COVID and started to see these long COVID patients, and you came to this field as well as some of your colleagues. And so reflecting on that, like what do you think it's going to take to get other providers to get attracted to this field and want to serve patients with these kind of chronic complex illnesses?
So it's going to take a lot of education. It's going to take a lot of policy change. It's going to take a lot of frame of mind. It's going to take a lot of research to better understand the pathophysiologic mechanisms. Because the fact that this type of disorders have been so neglected by funding for research, et cetera, has caused a gap in the knowledge, and the science is very much behind. So I'm hopeful that this pandemic, brings a surge and on research that can really solidify understanding of the pathophysiology of it. I think right now, and I'm going to be completely transparent, at an institution level where I'm working, I can see the differences in opinion in some of these more obscure illnesses, right? And it's because of the lack of science behind it. And I know that that's not the patient's fault, but I'm hopeful, like I said, because of the surgence of this mass disabling event that is the pandemic, this will bring more light into that, and we'll be able to, 1, educate providers, and 2, bring legislature and more of a clear understanding of the accommodations and benefits that these patients need in order to be taken care of. Yeah.
Mm-hmm. Mm-hmm. Yeah, and I see that Dave and Sue also added in the chat too that treating illnesses like ME/CFS or long COVID they could take a lot of time that physicians don't always have, especially when we have fairly short appointments where not everything may be covered at once, and it may take a long time to get at the root of different things and try to treat them. So maybe, so one idea it looks like that they have is to allow physicians to have more time to see these kinds of patients where more time is required.
It takes so much time. It takes so many emails. We're so taxed already. It's definitely, my experience creating this clinic has been that providers that were initially interested have stopped seeing patients in the clinic because they just find it difficult. So I find that most people have to have some sort of investment in the cost. So we see a lot of either providers that have family with these issues or have issues themselves that have an engagement and a more of a cost, right? Fight for the cost that are more engaged. But it's certainly a lot of ground to cover, but I think that the future at this point looks a little bit brighter because of the new population of this mass disabling event.
Yeah. So I just want to thank you all again for your time this afternoon, coming to speak with us. Dr. Azola, for sharing your perspective as the provider, and again, Dave and Sue, for sharing your family's experience. And I really appreciated hearing that because I could relate to a lot of aspects of that story too. So thank you for sharing. I just want to end our session with a few reminders about what's coming up. So we are going to have our next conversation in May, and that topic is going to be all about fibromyalgia. So the next date is going to be May 15th. Again, it's going to be 4 p.m. Eastern time. And our featured speaker will be Dr. Paul Monach, who is the chief of the rheumatology section in the Boston VA healthcare system. And he's an associate professor at Harvard Medical School. So this is going to be our first conversation dedicated to the topic of fibromyalgia this year. So I hope you can join us for that session. Also, if you have ideas for future programs or speakers, please do email us at events@massmecfs.org. We do want to hear what kind of presentations would be interesting to you, so we're willing to take those thoughts. The Sunday conversations are meant to be a program that will provide a variety of practical information that patients and families would need and want. So also, if you would like to join our Sunday conversations team, you can as well. So you can email volunteer@massmecfs.org. And we're working on the fall schedule right now, so let us know. And finally, if you found this program worthwhile, there are a few ways you can help. You may make a donation to help support this series by donating online at massmecfs.org/donate. On the same page, you can sign up for a newsletter, and if you donate $25 or more and check Become a Member option, that will establish or renew your membership, and you will be invited to our members-only programs. Thank you all for coming, and we hope to see you again next month.